Yes. Thank you, sir. Thanks, Sanofi, for giving this opportunity and supporting this. So what I'm going to talk, where sir left, the transforming diabetes care landscape with second generation basal insulin. What I'll be talking, the importance of insulin initiation and titration, the optimization of insulin therapy, and where I'll be talking the second generation insulin, and then practical consideration of use of second generation basal insulin, primarily targeting the glargine 300 IU. So sir had talked about the landmark trial or landmark data. So the Indian reality is 63% of our patients are uncontrolled, which is already been talked, but less than 1 in 4 Indians with established type 2 diabetes is taking insulin. Average A1C of our patients, even those who are started on insulin, is still 9.2, and that is something which is very, very surprising that already they are started, and there are 382 sites from all across the country with more than 6,000 patients. Data has been published. Even after insulin initiation, the 8 out of 10 patients failed to get control. And this is again, they are already started with insulin therapy still. 8 out of 10 patients, they are not controlled. This is one very nicely written a paper, a consensus document, which is generated by Delphi method, which is talking that in Asian countries, particularly in India, average titration dose of basal insulin remain around 18 units. In practice, in contrast, while in clinical trial, when we do a randomized clinical trial to achieve fasting control, the average dose comes around 40 units. So, in a real world, we are not up-titrating the dose more than 18 units, while in real world, that's the real world, while in randomized control trial, it goes up to 40 units. So, the average optimization dose of basal insulin, roughly less than 20 units, and a maximum dose, actually, which we should use it, is up to 0.5 unit per kg per day. 80% of maximum patients who are titrated occurs in the first 12 weeks following initiation. So when you are starting someone on a basal insulin, ideally they should be on self-monitoring, they should keep on checking their fasting blood glucose on their own, and they can up-titrate the dose of basal insulin, which is not done. And if you have not done like that, you have started whatever the dose which is there, and patient comes back to you after 3 months, and then to up-titrate that again becomes very difficult. Early response predicts long-term glycemic control. So if we can achieve a tight control when you are starting that, it will give you the maintenance dose of that control maybe another 24 months, maybe another 2 years. Early hypoglycemia, and that's again very important, it doubles the risk of future hypoglycemia events. So if while titrating the dose, when you are up titrating the dose, if someone develops hypoglycemia, it doubles the risk of future hypoglycemia, and early hypoglycemia increases the risk of treatment discontinuation also. There are multiple barriers for initiation of insulin as well as intensification, but one very important is a fear of hypoglycemia. We know that clinical inertia, non-adherence, there are a lot of misconception, fear of complex titration design. There may be many from patient's perspective as well as from healthcare professional. And one of the most important, which I feel, is a lack of time. That support system from the healthcare professional, a diabetologist or a physician who is not having sufficient time to teach or educate the patient. That is one of the most important barrier for intensifying the therapy, and that's maybe the reason even someone have started on a basal insulin, still it is not going more than 18 or 20. So our primarily interest is one side you have to achieve a glycemic control, but at the same time a person should not develop hypoglycemia. So the second generation is having the benefit of less hypoglycemia. They are flexible in dosing because the same time, giving at the same time, like if you have started with a glargine 100, it is 9, so probably that patient has to do around the same time, while here it gives you the flexibility, stable and a prolonged action for more than 24 hours, less glycemic variability, effective and a very sustained glycemic control. Overall hypoglycemia is less and nocturnal hypoglycemia is less with the minimal weight gain, and there is a safety also during titration period too. Do we have evidence when we talk about all these points? Yes, we have a strong evidence for glargine 300. If you go back that in PK/PD sampling, which was then addition program, then there is a deliver, which was a randomized control, real world data, then randomized control trial with type 1 diabetic patient who are already at higher risk of hypoglycemia, then a real world data again, then again it was compared with degludec, where there was a pharmacokinetic study and pharmacodynamic study versus degludec patients with high hypoglycemia risk against degludec. It was a randomized control trial. Again, bright study, which was a RCT, and then real world data also which in type 1 diabetes, which was one care study, and then randomized control trial with type 1 diabetes. So we have in compared with degludec, we have in comparison with glargine 100, and you can see the multiple studies and strong evidence, scientific evidence which we have with glargine 300. Let me talk about the addition program. The objective was to assess the clinical efficacy and safety of glargine versus glargine 100 IU. Randomized, it was 1:1, open label, parallel group, multi-center, phase 3 study. Addition program was built with similar study design across trial to confirm the results. It was for 6 months, and then 6-month extension period was there. And what we have seen, it lead to glargine 300 in compared to glargine 100 IU, reduce hypoglycemia during titration period. And that's very important period. As I told you, the first 3 months, if you can titrate, that's the best time, and that's also the risk of hypoglycemia during titration is also very high. So if you see that type 2, addition 1, addition 2, 3, and addition dedicated Japan, that is study 2, they all favor glargine 300 in nocturnal hypoglycemia. Even in type 1 diabetes, which is addition 4 and addition GP1, which had also favored the glargine 300 IU in compared to glargine IU 100. Any time of the hypoglycemia, I mean just not the nocturnal hypoglycemia, you can see it favors glargine 300 IU in compared to glargine 100 in all these studies. So none of these study, whether it's a type 1, type 2, nocturnal hypoglycemia, all-time hypoglycemia, it was less in the people who were on glargine 300. The patient level meta-analysis, this is in addition 1 to 3 study, which has shown that both the arm had shown HbA1c reduction almost same, with the nocturnal hypoglycemia reduction was relative 42%, with less anytime hypoglycemia of 23%, and less weight gain. That's very important. But definitely less hypoglycemia, less weight gain was there, and more sustained HbA1c reduction with lower hypoglycemia, weight gain, lower weight gain in compared to glargine 100 in glargine 300. Then there is a bright study, which is a comparison of glargine 300 with insulin degludec 100 in insulin naive patients of type 2 diabetic patient. One arm was on a 466 patient on glargine 300 IU, other arm was on insulin degludec on 100 once daily. Both were given at the bedtime. Titration period was for 12 weeks, and there was a maintenance period of 13 to 24 weeks, and then they were followed up for post-treatment for 7 days. And these patients were uncontrolled diabetic patients on multiple oral antidiabetic agents, maybe plus minus GLP-1. And what we had seen, the HbA1c level over 24 weeks of the treatment, you can see here in both the arms, it is almost same with the glargine 100 and glargine, degludec 100 versus glargine 300. The baseline HbA1c was around 8.7 to 8.6, and after week 24, it was both the arms achieved 7, which both the arms reduce in comparable improvement in glycemic control. But there is a lower hypoglycemia with glargine 300 in compared to insulin degludec during titration period, when you have to titrate on your own to achieve the fasting plasma glucose less than 110. Incidence of any time confirmed hypoglycemia, which is less than 70, was less in insulin glargine arm 300 IU, 26% less. Incidence of any time confirmed hypoglycemia, which is less than 54, again it was 37% relatively less. Event rate of any time confirmed hypoglycemia, again less than 70 we have calculated. Event of any confirmed hypoglycemia less than 54, 43% less risk of hypoglycemia, and event of nocturnal confirmed hypoglycemia 35% 10% relative risk reduction of hypoglycemia. So early hypoglycemic events during titration are associated with increased risk of treatment discontinuation as well as long-term risk of hypoglycemia, which I told you that, in early case, if someone develops hypoglycemia, it doubles the risk of further getting hypoglycemia also. And glargine 300 may offer an advantage of a hypoglycemic risk reduction, what says insulin degludec, during the titration period in insulin naive patients with type 2 diabetic patient. If we, this is a euglycemic clamp, and you can see here, there is a 22% greater insulin peak was seen in insulin degludec arm in compared to glargine 300, and that has led to 23% lesser within day variability with glargine 300 in compared to insulin degludec. So in type 1 diabetes, who are naive to glargine 300 or degludec, with individual clinical doses of glargine 300, which was around 0.34 to 0.08 unit per kg, and degludec dosing both at night time at 8 p.m. after 3 months of optimal titration of basal bolus dose. And you can see here there was a greater insulin peak was in degludec arm and less glycemic variability patients who are on glargine 300 IU. Initiating, this was one more, Pro, which is a post hoc analysis, evaluated meaningful improvement in diabetes treatment satisfaction questionnaire scores with glycemic parameter, which was done at baseline, month 3, 6 and 12. And here you can see the changes in the treatment, the inconvenience, the lifestyle, the hypoglycemic control, the glycemic control and delivery system. In all these, there was a improved satisfaction with the glargine 300 in persistence, enhanced quality of life, and decrease in perceived frequency of hyper and hypoglycemia associated with decreased A1C also. So what the practical consideration of use of glargine 300? What is the initiation dose? We start with the 0.2 unit, that's the same. What is the preferred timing? Any time of the day, but it should be on the same time. That is what we say, but there is a flexibility. But even we say the person to take every day on 9 p.m. There is a possibility sometime we may take on 7 or 8 or sometime even 10 or 11. So that's what we can say. Can OAD be discontinued? No, the same, the glargine we have to continue and can be safely titrated using daily, once in 3 days, or weekly titration schedule. I do twice in a week, someone can do once in a week, but that we can decide. But self titration is very, very important. Up to what dose can glargine be titrated? This very important. We have to say the patient that up to 0.5 unit per kg. So it's not just 18, 20, 24 units should be and then stop. You can say that yes, we are starting with 0.2, but it can be titrated, or in between there can be a telephonic visit. What are the unique advantages of glargine 300 over first generation? One is the duration is more than 24 hours. It's a longer acting, less variability. There is a flexibility of plus minus 3 hours, low hypo, low weight gain and safer titration. It is important that these challenging times to go treatment strategies that offer better control of all glycemic indicators. And we know that person is not actually titrating the dose just because of worrying of hypoglycemia. That's a major challenge. The device is also very convenient. It has dedicated cartridge, it clear dose display and flexible dose selection. It has got simple dose delivery system. You can see here even 0, 1, 2, everything is written up to 80 units. So I mean, normally in India our requirement will not go more than 50, because average persons with a weight to whom we are starting maybe between 70 to 100. Penalty-free dose correction, mechanical last dose stop, short dial extension, hold time of 5 seconds, 1 unit adjustment is there, and total capacity is 450 units. So I mean, this is what mostly we start the patients around 15 units. Some patients who are overweight or obese maybe up to 20 units. So 10 to 15 days, 20 days, they can self-titrate and then they can take the second one. To summarize my talk, it is very effective and sustained glycemic control, which is very important, and what for which we are treating type 2 diabetic patients or type 1 diabetes and initiating insulin, but still 8 out of 10 are not getting good control. So that's very important. It should be very safe during titration and maintenance period. That is what we ask the persons to do. The titration and self titration is very important. Improved quality of life and patient satisfaction, a flexible dosing of plus minus 3 hours, a reduced weight gain even after starting them on insulin. insulin, still the weight gain is not significant in compared to the older insulin. Reduce overall hypoglycemia and particularly nocturnal hypoglycemia, and a once daily injection, and that too less painful with a newer device which we have, and a full day coverage with lower glycemic variability. With this, I once again thank you, Dr. V.Mohan sir, and thanking everyone with inviting you, all of you, and Diabetes India at World Congress of Diabetes India in Hyderabad from 12 to 15. Thank you, sir.